supposed to do. It's not streaming. Okay, here we go. It's not connecting. Come on. Okay. All right, now.
The radical, fundamental principles of freedom, rational self-interest, and individual rights. This is the Yaron Brook Show.
All right, welcome everybody. The Yaron Brook Show on this Friday afternoon. Not a typical time of day for me to do a show, but we have, I think, a unique opportunity to talk to a friend and somebody who I admire greatly, but who's unbelievably busy right now. So I basically told him any time of day, just let me know. And that is Amesh Adalja, who many of you know because he's been on the show before. He is an expert in infectious disease and an emergency room doctor, you know, so he's really experienced everything that's going on right now. And of course, he's doing, I don't know how many interviews a day, but you can see him on, I've seen him on CNN, MSNBC, and Fox, but I'm sure he's on radio and on a bunch of other TV shows as well. So thanks, Amesh. I really appreciate you joining us. I know how busy you are.
And thanks for having me back.
Sure, absolutely. So, I mean, I have a ton of questions, and I'm sure everybody has a ton of questions. There's so much going on, and there's so much uncertainty, and there's so many different voices you hear, and it gets confusing, even if you're trying to be super rational and trying to analyze everything. There's just so much. So let's start with just a general question of how bad are things right now? Do you think things are getting better? I mean, where are we kind of in the cycle of this thing?
Well, it depends on where you're sitting, because different parts of the country and different parts of the world are kind of having asynchronous outbreaks. It's not one big outbreak, it's many little outbreaks. And I think if you're looking at the United States, for example, I think we're over the worst of it, at least for this part of the outbreak. We really had our eyes on New York City, which was kind of the canary in the coal mine, where there really was a crisis on the verge of happening, where we were really worried that people might have to ration ventilators and that we would see lots of excess deaths. And New York City averted the worst of it. I can't say that it wasn't something that was pretty horrific for the doctors that work there. We know doctors have committed suicide there. This is something that everybody was watching and using that to try and understand what would happen in the rest of the country. And as New York City went through its peak and survived, you've seen a difference, kind of a sigh of relief in the rest of the country. And now you're starting to see this opening up, because much of what happened in the United States was premised on what happened in New York City. Worldwide, you're seeing cases occur again in places like Singapore and China, and somewhat in South Korea as well. And that's expected, because the virus didn't go anywhere. It's like we said before, when I was on a long time ago, this was something that was already established in the human population. Without a vaccine, you're going to expect to see surges. We haven't seen a lot of cases in some of the developing world yet, at least reported cases. So people are very eager to see what happens in parts of sub-Saharan Africa and in India, for example, where they may have major issues with population density in some of those mega cities, as well as having really poor access to healthcare. And they know they've been hit disproportionately bad during 2009 H1N1. So that's something that we're still not over. So those countries, and this is going to go on for some time, we're going to be dealing with coronavirus until there's a vaccine. So I think probably for at least 2 more years, you're going to be hearing a lot about coronavirus and learning how to live with it and trying to find the right balance of controlling the virus and keeping the economies functioning in the world.
So part of the, I think the challenge of keeping track of all of this is kind of some geographic differences in response. So if we take South Korea, and we talked about this last time of how South Korea's response was about as good as it can get, I guess. And I don't know if you still think that, but it's obviously, in terms of outcome, has had really positive outcome. But then why is it that it hasn't come back stronger, given that they haven't really had as much social distancing, no travel restrictions, as far as I know, really, in South Korea? Why don't we see this as a constant kind of up and down with them? They get a few cases, but it doesn't seem like it's anything dramatic.
It's hard to say exactly what's going on in all those countries. We know that South Korea acted really quickly, took all the right actions, exactly as if you were writing like a textbook on how to respond to an emerging infectious disease outbreak. That's what they did. And they got a lot of reward for it because they didn't have that type of death. But don't suspect that they're not going to have mild cases. It could be that or more cases occurring. I think it could be the fact that how much travel is occurring outside of the country. Did they get all of their cases extinguished, and there's maybe a small ebb and flow of imported cases that are coming from other places? Because I know international travel is down everywhere, and that may be something, because when you look at places like China, for example, they're getting cases that are imported from other parts of the world. And it may be that travel restrictions that have occurred there have kept their cases low. But the overall goal in all of these places is not going to be to keep cases to zero. That's impossible. It's going to be keep cases below a level that the hospitals can handle them. And I think that's what you have to do everywhere. And that's the metric to use, because this is going to happen everywhere, that when they open, they're going to say, oh, they've opened too early. And it's not just because cases go up, it's because the cases put their hospitals in problems. So you're hearing about Japan, at least I think on the island of Hokkaido, where they had to reinstitute an emergency declaration because the cases went up too quickly after they peeled back. So this is going to be kind of this tug of war with this virus, trying to see how much we can do safely before we get into another crisis. And it may not happen in every place. It's really going to be dependent on population density and hospital capacity in each geographic area. So there's no easy answers here.
Yeah, I think the numbers in the new cases in Singapore, the numbers I saw of overwhelmingly in kind of the migrant worker populations. They're in these dormitories where these migrant workers live in very, very tight, living spaces. And they travel in and out of Malaysia. Most of the migrant workers are Malay. And that's where I think it was something like 90% of all the new cases had actually.
Singapore has a very unique outbreak, and they have a very unique system where all these migrant workers in the dormitories that they live in are really going to be hotbeds for spread because they don't social distance as well there. And Singapore is interesting because it was a case where they didn't close schools. And I think that's an example lots of us are using when we're trying to argue for opening schools back up in the United States.
So speaking about a place that didn't close schools, what is your sense of what is happening in Sweden, what we can learn from it, and whether, because you read, it's horrible how politicized, right? Everything has come. So some news outlets are all for Sweden and anything they do is fantastic. Other news outlets, it's, Sweden is the devil and everything they do is horrific. So what's your sense of how Sweden has done in this crisis?
So you have to expect, if you allow the virus to go, that you're going to get more deaths. And that's what they have, more deaths per capita. Their death rate is increasing, and they're getting a lot of criticism for it. It's unclear to me what their hospital capacity is and how much hospital capacity they have to spare. This is kind of, I would say, almost a societal value judgment that they made, that this is the way that they were going to do this. Most of their deaths have been in nursing home patients. And I know that some of these Scandinavian countries are much different about end-of-life care than places like the United States, for example. So I think that this is maybe a philosophical difference that we're seeing underlying this. I do think they're going to get more deaths. They're going to be criticized for that. They may reach herd immunity, but it may be a very big societal cost. And they're not completely letting everything open. Obviously, certain mass gatherings are banned. People are social distancing, teleworking. It's not quite nearly as like what we're doing in the United States. But this is something that I think really is explained by the underlying philosophical approach they took. And I don't think if we would have not done anything in New York City, those hospitals would have probably caved. It would have went into crisis standards of care with rationing. So I do think that there were hotspots in the United States that if no action were taken, we would have been in a disaster, a worse disaster than we were already in. So I think that this type of a solution isn't what you can do in every place. It really has to be geographically driven. And the jury is still out on exactly what happens with Sweden. And they are going to take a lot of criticism because they made that decision.
And it's interesting to me that Sweden chose to do this and at the same time didn't do the kind of testing and kind of tracking and isolating, nowhere near to the extent that somewhere like South Korea did. So you'd think that they would combine the two and not just leave society open, but not engage in the testing.
Yeah, so I think that's also something to come up with to criticize them, because if you were going to do that, you want to make sure you could easily spiral out of control to a point where hospitals can't handle it. And the only way you're going to keep that down is by at least doing testing and doing isolation of infected cases and trying to understand their contacts and keeping track of all of that. So to do this kind of they kind of took the false alternative of letting the virus completely go as much as you could with some social distancing versus a Wuhan style lockdown where you basically had a police state type of tactic.
Yeah. I've also read somewhere that in Sweden's case, the primary deaths are obviously in nursing homes, but also they've got a huge immigrant population from the Middle East, which again, don't socially distance and, so very similar to Singapore, and who live in very confined spaces and multi-generational spaces. So they're not typical traditional Swedes who tend to socially distance almost naturally and don't have that. So, they've got a little bit of that Singapore, aspect to them where they have two kind of societies in the same space. Anywhere else in the world where you're seeing, things being done a little differently or where the response is being unusual or unexpected?
I would say Taiwan is a good example to bring about. Taiwan is a country that has been very aggressive. I was part of a team that evaluated Taiwan 10 years after SARS, so I spent a lot of time there understanding their system, and they basically pounced on this virus as soon as they heard about it and started to really be aggressive with testing and ensuring that they weren't going to have anything basically enter their island and collapse their island. And I think Taiwan is a good example. And one of the injustices of this whole thing is that Taiwan isn't talked about because they're not members of the WHO. They're prohibited from being in the WHO, not because they did anything wrong, but because they did something right. They respect individual rights, and China does not allow them there. And I think that's really one of the stories that needs to be told. And the Taiwanese vice president is actually a PhD epidemiologist, as far as I know. So they're very good. And most of these Taiwanese infectious disease experts are all trained in America. They're really, really top of the line. And one of them the vice president just gave a webinar. I think it's available on the Johns Hopkins website where they talked about their experience. So I think this is a great success story, again, for Taiwan, which is horribly overlooked all the time. It's tragic. And it's not just the WHO, of course. They're not in the UN. They're the only country, the only state that's not a member of the United Nations. The United States does not have an embassy in Taiwan. There is an institute for something that serves the equivalent of an embassy, but there's no official diplomatic relations, as ridiculous and absurd as that is, between the United States and the Taiwanese government. And their sin is that they are free, and as compared to China, which is an authoritarian regime. To what extent is there any evidence that COVID is mutated so that, let's say, it's more deadly in Europe than it is in Asia, more deadly in New York than it was on the West Coast where it was first discovered? No, it's important to remember that all viruses mutate. Most mutations have no functional significance, and we haven't seen any mutation that's changed the behavior of this virus. What a virus does in a certain area is more a reflection of who it's infecting. Is it infecting older people? Is it infecting nursing home patients? The United States has a very high problem with obesity and diabetes and hypertension. So you will see differing death rates depending upon what the levels of those cofactors are. It's not the virus, it's actually the host that's actually driving what happens. And you can see if you look at the mortality rate in somebody above 70, it's probably 15 to 20% versus that gets hospitalized versus someone who's less than 18, where it's probably 0.001% or something like that, or even lower than that. Lower than that, yeah. And is it really the nature of the population and where the virus entered that is the difference between, let's say, Seattle, where it first entered, and it was pretty deadly. I mean, you remember that nursing home that just got crushed in Seattle, which was tragic. And then in New York, where it seems to have just, particularly in Brooklyn and I guess Queens and the Bronx, the people who probably commuted into the city, there it just has been devastating. Yeah, it definitely has to do with where it goes, what the population density is, how easy it can spread, what the state of the hospitals are. And if you go into a nursing home, it can really basically run rampant in a nursing home where people have very, very little reserve to fight off any type of infection, let alone something like this. So this is something that we expected to see be a really important thing to get nursing homes fortified. And many nursing homes now are basically on lockdown where there's no visitors allowed, because that can, if you think of a nursing home, maybe has 200 people in it, if in a small town, that could destroy your hospital if a nursing home gets infected. So it's really important, even as we go forward, as we start opening up, that nursing homes particularly be guarded well from this virus, because those people are at high risk, and we really need to make sure that they're not getting infected. to a degree that causes the hospitals to crash. But I do think that it has to do with the comorbidities and where they are. And it's definitely, that's probably what the final verdict will be on Lombardy and Italy of why that spiraled out of control, was the average age there and who was getting infected versus who gets infected in another place like maybe Germany, where there was the younger age where people got infected.
So what do you think about the people, there seem to be a lot of them, who take a part of the United States where this is not really being very deadly and then extrapolate, right? And then say, this is just a flu. This is nothing different than the flu.
Yeah, so that's completely wrong. It's not just a flu. And the fact is that there were certain factors that made it much more deadly in New York than in Peoria, Illinois, or where, the Midwest, or anywhere you pick, even in Pittsburgh where I'm sitting. And you have to realize that this is a new virus that no human has any kind of protection against it. And the fact is, even if it has a case fatality ratio of 0.5%, the fact that it can infect everybody, that's a lot of people. A small percentage of a big number is still a big number. And that's what you have to do. You have to think about. And the fact that your city didn't get hit has to do with the fact that you can't say that social distancing didn't do anything, because people did start to put social distancing in place and did dampen it in many other places, because everybody had the experience of watching New York and watching Seattle. And that's what caused that cascading domino effect of all of these governors, because there wasn't really federal guidance at this time. It was basically, we're seeing what's happening in New York and Seattle. We're scared. We need to take action. And they did. And we're spared in many places. And I think now we're beginning to learn that you can't extrapolate what happened in New York to everywhere, but the converse is true as well. You can't say that this was an overreaction in places like New York City, because it clearly was not. And it may have been an underreaction in New York, because New York didn't do things quite quick enough. When they had those first cases, the contact tracing, all of that kind of slipped through the cracks in New York. So I do think that there's, on both sides of this, the false alternatives are being presented all over the place. And the whole thing has become politicized now, which has made it very hard for anybody to have any kind of objective opinion and not be pushed into one of those camps. But no, this is not like the flu. This is killing at a much higher portion of the population is going to die from this than dies of flu every year. And I think that that's an important thing to do. This isn't something that is easy to deal with. And if you've seen these patients dying, it is very challenging to take care of them. And this shouldn't be minimized in any way, because it's not as bad. It's not apocalyptic. Doesn't mean that it's not bad.
Yeah, and when you say it's 0.5%, that's 5 times the flu. 5 times the death rate is a big number. It's not like 20% more, 30% more. It's it's 600% more. Right?
Yeah, we still don't know quite the number, but that's kind of the number that's where people are starting to settle looking at it. And I think it's obviously that's an average number, so it's much higher in certain age groups and much lower in other groups. But this is much more challenging to deal with than the flu. And with flu, we have a vaccine, we have antivirals. We don't have any of that with this.
Yeah, I mean, you told me well over a month ago that the number was about 0.6. So you were right on top of this from the beginning in terms of how deadly this probably would be. And those are the numbers coming out, I think, South Korea and some of the other places at the time. So if we take New York, and I know this is speculation, but do you think if the right actions would have been taken in time, given that the Chinese delayed and we didn't know about this early enough and everything, but if the right actions had been taken when we had the information, could a lockdown have been avoidable in New York City?
I think they would have had to have initiated some social distancing, but not nearly what happened there. And I don't think we would have let this spiral out of control, because remember, we knew by January that this was going on, that there was human-to-human spread, that it was a respiratory virus. All of that tells you this is not a containable virus. I told you that on the show a long time ago, that it was going to be here. And we're now learning, for example, the first death was at least February 6th in Santa Clara County in California, which means that person got infected probably early January. So this was already here when we were having that conversation, as I thought was the case. So if you would have at that time started to say, okay, we know this is here. We're not going to have these silly restrictions on testing and say they have to be just from China, because we know this virus has long escaped China. And we know that there's mild cases, and mild cases are contagious. We're not just going to test severe cases. If you would have put that into place, got the diagnostic companies working at that time, Quest and LabCorp, these big national chains, and removed all the bureaucracy, then said, we need to get case contact tracers. We need to not let any case basically slip through because we have so few. And then get rid of these ideas of silly travel bans from places where the virus was, but it wasn't any longer. We didn't know where the virus was and wasn't. So how can you say, let's ban flights from China, but not ban flights from other countries when there were cases at that time in many different countries, and all the resources and distraction and the false sense of security that caused, and really got on top of it. I think you could have avoided a lot of the shutdowns. You may, especially ones in, that encompass the whole entire country. You may still have had some modifications in places where that got hit hard. New York still probably was going to be a high risk place just because of the population density and the cosmopolitan nature of it. But I think you could have avoided a lot of what happened if we would have done this right. And there was no excuse for not doing it right, because people in my field have been, including me, have been talking about this for years and years and years, writing reports and report after report, telling them this is exactly what's going to happen if you don't do this. And then they actually didn't do what we said that they should do.
And I assume the CDC had a plan, right? And then didn't execute it. Is it because of lack of leadership or political issues?
So I don't know exactly all the stuff that happened behind the scenes. I do know that the CDC are the most adept, expert people at doing this. And I've learned a lot from the CDC, and I've been on CDC panels, and I respect them very, very highly. But I do think they were constrained by the environment in a way that wasn't really fair. So there was a woman, so the National Center for Infectious and Respiratory Diseases was the one taking the lead. That's part of the CDC, Nancy Messonnier. She was the main person speaking about this. And when she started warning of a pandemic in February, where'd she go? She look at her Twitter accounts, that she got criticized. Do you know who her brother is?
No.
It's Rod Rosenstein. The president, that person basically got sidelined. Somebody that was trying to warn the American public to get them ready beforehand. That wasn't something that was considered good by the powers that be, because it affected the stock market. So the CDC definitely has, and there's been many articles talking about the CDC losing its voice here. And that's definitely something. When the CDC is not the one speaking, we definitely do worse as a country. We want the CDC director talking to the American public every day about what to do, because we know that they know how to do this, and they've been planning for this, and they have the best experts in the world.
Now, there's a lot of differing views about Dr. Fauci, who now has a kind of a main voice and communicated with the American people, at least sometimes, I guess, depending on the mood. But so I don't know what to make of him. I mean, I admire him for standing up to Trump, which I think is really, really hard. But I don't know what to make of him. What is your assessment of Fauci?
I think he's a brilliant physician that has made major breakthroughs in science, and that's why he's been at the National Institute of Allergy and Infectious Disease. He basically followed his mentor there, and he's somebody that's not just brilliant in infectious disease, but anything involving the immune system. And he made major breakthroughs and changed the paradigm for treating certain autoimmune disorders, and then was a pioneer in HIV, and has been through many different administrations trying to he kind of has a policy role as well as a scientist role, which is kind of a hard thing to do. And I think he's really been a voice of reason there, and something that everybody looks to because of the experience he's had, and the fact that he can speak so straight to the American public and has that credibility. So I do think that he, he's one of the icons in the field, and somebody that I greatly admire. I think that what happens is you have people in our field that are laser focused on this virus, and that's what they're paid to do. That's what he's being asked to do, is to stop this virus. So some people may disagree with the policy prescriptions, but those policy prescriptions are just what he's saying. If you want to do this, if you want to control this virus, these are what you need to do. This is what you need to do. And I think that sometimes then it's up to the policymakers, the politicians, to actually implement that and make the decisions. So I think blaming him for doing his job is probably the wrong thing to do. And I think that, if it were not for him, I think there would be a lot of horrible decisions that had been made, would have been made without his counsel. And the fact that people worry when he's not at a press conference is actually something that keeps the White House task force on point, and keeps the president from making decisions that would not be scientifically based. And we see what he's already tried to do with multiple different examples, so numerous you can't even count them.
Sure. Somebody's asking, when do you think we'll know if getting the disease actually gives you immunity?
So what we think with most infectious diseases is once you get infected, you have some level of immunity for some period of time. That's usually on the matter of months. But we know with other coronaviruses that your immunity wanes over about a period of a year, and you can be reinfected, at least experimentally. So I think it'll probably take a year to know exactly if people can be reinfected at that time. I don't suspect if you just got infected this month that you're going to be able to be reinfected in the next day or so. And I think the question is, how durable is that immunity?
So what about those cases in South Korea where they seem to have people who had it recently have been reinfected?
So it's important to remember the test's not testing for the viable virus. It's just testing for genetic material. And it's now been shown that, and this is what we all suspected, was that those people, when you get this virus, it damages parts of your lungs, and there's debris, and people cough that up over a period of time. And what ended up happening was that virus was actually debris mixed in with debris that was clearing from their lung. They couldn't actually culture the virus. It's just testing for the genetic material. So those people were not not reinfected.
Yeah, good. That's good news. So there is such a thing as herd immunity, and it ultimately could happen even without a vaccine. But a lot of people would die in the process. Is that?
Yes, yeah. You need to get probably at least 60% or higher of the population infected, and that's going to come at a huge cost. So if we can, we don't really want to do that if we can avoid it, especially because there are certain, you can't really, we talk about cocooning the elderly, and I think we need to cocoon the elderly as best as we can, but you can't, it's not ironclad. And I think you have to really be careful about how you do that, because there's going to be interactions between high risk individuals and low risk individuals. And I wish there was a way to hermetically seal them off so that you don't do that, but it's not an easy thing to do. And you're seeing that in Sweden, for example.
So is it true to say that if we do open up, and I expect we will, different paces in different places, that more people will die? I mean, that's just the reality.
Yes, it is true. This isn't gone anywhere, and flattening the curve was never really about saving lives. It was preventing excess deaths. It was trying to spread out the same number of cases over a longer period of time. This has really been about hospital capacity. And right now, there's some people trying to move the goalposts here, and that's not what this was about. It was about hospital capacity. So, for example, in Georgia, they are talking about the fact that they're going to get more cases, they're going to get more deaths, and they're going to have beds. And I heard the Atlanta mayor say something like, those are beds to die in, to say that, so it doesn't matter because we're trying to save lives. But there's no way to do that when you're dealing with an outbreak that's not going away. This is not a containable virus. So the American people have to realize that the number of cases is going to continue. As soon as you start peeling back social distancing, the cases are going to go up. We expect that. This is about preserving hospital capacity. And I think that needs to be the overriding philosophical principle that everybody has in mind, because there's lots of people who misunderstand this. And I think it's because of the way this was presented by policymakers to the general public that they don't quite understand what flattening the curve actually meant. It's the same area under the curve. It's just happening over a longer period of time.
And I mean, the only way in which that would change is if we actually got a treatment, right? That it was actually efficacious. Yes.
So we did buy some time with this, and we do have some good data coming out on Gilead's product where people improve much quicker. We didn't get a mortality benefit, but we get them out of the hospital faster if they get this treatment, which helps us with hospital capacity. So that is something that's good. Hopefully we will get some treatments that can change mortality. Maybe they'll do more studies on the Gilead drug in different patient populations showing a mortality benefit. That would be great. There are other drugs. There's so many drugs that are in clinical trials right now that I can't keep track of them all. And we are moving really rapidly towards a vaccine, which was really what we need to have. That's the only way that we remove this threat. But yes, if we could get something that decreased mortality, that would be really a huge benefit.
So, and what is your sense of success, of the progress there, and what do you think of the malaria drug and zinc and the combinations and all of the studies that have come out about that sometimes seem contradictory?
So hydroxychloroquine and chloroquine are two drugs that have been around for a long time that are used for malaria and some autoimmune conditions. And these have generic antiviral effects and immune modulating effects and stuff in a test tube that works against coronavirus, but they had never been put up against the coronavirus. And they're not, even though they're approved and we give them to people, that doesn't mean that they're without side effects. Every drug has a side effect, and every person there's a risk benefit calculation you have to take. And they hadn't been studied for coronavirus. And what we're seeing is people I actually prescribed it to two people before based on hospital-based protocols, but we needed a randomized controlled trial, and we still need a randomized controlled trial to actually know whether it works or not. But what we're finding is that the more and more data comes out, it doesn't appear to necessarily have any real benefit here, and there is there is toxicity. these drugs do have side effects, and these side effects are different when you're giving them to a person who's not in the hospital, who's outside, who's got rheumatoid arthritis, which is a debilitating disease, and you give it. That's a different side effect tolerance than someone who's got a mild case of the coronavirus that may not need them, or someone who's hospitalized and really, really sick and already having heart rhythm problems, and then you're giving this drug to. So I think that all of that kind of got lost in the debate because you had people, irresponsibly claiming that this is going to be this panacea, that everybody should be taking it. You had patients that, I know firsthand patients that were asked to be in the clinical trial for it. They wouldn't go in the clinical trial because the president said they should just take it anyway. So these statements were actually hampering our ability to actually find out the true answer to this. And you can see now, in the middle of this whole thing, the FDA had to issue an advisory saying this is a toxic drug. We don't recommend you give this without cardiac monitoring. So it really, when politicians get into the science business, they can really foul things up. And I think the hydroxychloroquine example is a great one, where science was really completely politicized, and you were either on the hydroxychloroquine camp or you weren't on the hydroxychloroquine camp. And I think that really made it much, much worse than it had to be. I don't suspect it's going to be one of our best drugs against this. I think that remdesivir, the Gilead drug, looks good. And I think their convalescent plasma, giving blood from survivors, that may likely have a benefit. And there are other things that are going to come down the line. But I don't think that hydroxychloroquine is going to be the answer for this. But I want to get the trial results before I say definitively. And hopefully that randomized control trial will finish soon.
Somebody's asking if you have any thoughts on New Zealand's strategy, which was to completely eliminate the virus and then keep the country locked down from the outside, so nobody coming in.
So island nations can do things that are very different than other places. So New Zealand also has like 5 million population of 5 million. So this is important. There's no one size fits all type of thing. Each country has to look at their own demographics, their hospital capacity, what their travel patterns are, and then make a decision. And I know that the prime minister there, she's getting a lot of praise for this, and people think she's very effective. And I think she does deserve credit for keeping her country safe. But I think that it's not necessarily applicable everywhere. Obviously, you can do that if you're an island nation, and Hawaii or something a state could do that if they have ways of completely isolating themselves in this type of atmosphere. But it's not going to be something that you can do everywhere. And I think New Zealand, with its population density and the way their society functions, this was a good solution for them. But it's probably not the same solution that you can use in other countries.
And they're going to have to be vigilant, right? Because the virus there's potential for it to come back. They can't completely forever. The island, right?
Yes, you can't do this forever, and they have to come up with a plan. And maybe that's very strict screening when people come into there, and really having all of the apparatus in place to catch these cases and isolate them. But this is something that we often find island nations are really good at infectious diseases because they have this natural barrier that other places don't.
Well, in Iceland, combined that with huge amount of testing, right, and tracking, and they're I think culturally it's much easier to do the testing, tracking, isolating than it is in other countries.
Yes, I think if you have that ability to do it in a small population, then it's a totally different game than dealing with the United States, where you have over 300 million people, and most of them don't want to do anything that has tracking or any kind of thing like that. In Iceland, I think, don't they have apps to tell if you're related to each other? I think yes. They have lots of apps there that you can harness that kind of information to do.
So when you're dating in Iceland, you check the app to make sure you're not dating a cousin, because everybody's related there. So you want to know how many degrees of separation there are. Do we have more information now about the extent to which this might or might not be seasonal?
So we know other coronaviruses are seasonal. This virus has a couple things going for it. So the thing is that we have no population immunity. So that means that human to human spread will continue. What we do know is that this virus has biological characteristics just like other coronaviruses. So on surfaces, when it gets hotter, when it's sunnier, when the humidity changes, the virus's viability will change. And so that will probably decrease transmission from surfaces, but that doesn't mean it's going to decrease transmission from person to person. And there's so many people that are infected, and there's so much immunity that's lacking in the population that we probably won't see a full dampening of this in summer in temperate climates. We may see some lower transmission from surfaces, but not completely. And I do think we will probably see acceleration in the fall when the environmental characteristics favor its transmission. So I don't think we'll see seasonality, at least until we get enough population immunity that it can be more seasonal like the other coronaviruses. And it's important to say that when I'm talking about UV light and all that stuff, that means on surfaces, not in your body. I hate that I have to say that, but people have confused about what UV light means, and you should not be putting UV radiation into your body or anything like that.
So as we move here into the next few months, into the summer, as the case may be, and then coming out of the fall, what are you looking at? What are the numbers? What kind of numbers do you look at? Is it mortality? Is it caseload? What is it? And then what are going to be positive and negative signs in terms of how this evolves? I mean, it sounds like from you that it's likely to dull out and then increase again in the fall. How certain are you of that? And what are you going to be looking at to see how this happens?
I'm certain we're going to be dealing with this in fall. I don't know if it'll completely decrease in the summer. I think we may get some respite from it, but not complete. It'll still continue to spread here. And we're seeing that in other parts of the world where there is tropical weather conditions or warm weather conditions. It's still spreading because there's so many people that are infected. What I look at, a couple of things. I look at hospitalization rates. I look and seeing, how many people are in the hospital with this, how many people are on ventilators with this. Those are things that I really look at because that's going to trigger when you get more needs for social distancing, if that ever gets exceeded again. I also look at the percent positive of tests. I don't look at the number of cases because I know there's going to be a lot of cases because we're not testing enough. But if your testing is flat or going up and your percent positive rate is going down or stable, I think that's a good sign. So right now in the United States, we're in the teens, maybe 14 to 16% of our tests that we do overall are positive. We want that to go as low as possible. It's not going to go to zero, but there's no magic number there, but I just like to look at that trend to say, obviously, if it's in some place and it's 30%, that's really too high. But if it's in the teens or if it's getting closer to 10%, that's a better number, saying that we're actually doing enough testing to find the cases. So that's something I look at. And I do a lot of qualitative stuff. I just call up my friends in different hotspots and say, what's it like? That helps me to kind of reality test, because I know what I'm seeing in the hospital here, but I'm in Pittsburgh and Pittsburgh is less connected. Even though it's a biggish city, it's not the same thing as being in New York City or San Francisco. So I like to just randomly call people and say, how does it look there? What's going on? And I think that gives me a lot of reality to kind of come up with a kind of an inductive approach where I take all of this together and kind of come up with my general thought on it.
So how much is the decision making being done today at the state levels and at the federal level? But I think most of the decisions that affect our lives are being done actually at the state level. Based on science, how much of it is based on politics, on economics? And do you think that mixture, whatever the mixture is the right one to the extent that you have an opinion on that?
So definitely all the decisions are being made at the states and at state levels, and states have their own departments of health. They have their own advisory panels, and there's going to be differing voices because, I'm giving you my perspective on my analysis as based on my understanding of this, but there are people that I work with every day that have completely diametrically opposed views on this. So there are going to be differing voices, and each governor is influenced by different members of that. Hopefully they're getting enough from both sides so they can come up with something. But I do think that there is a lot of politics involved because you're already seeing this kind of red state, blue state type of division happening. And it even occurs depending upon what the legislature is. If the legislature red, is the legislature blue? What can the governor get away with? Is the governor up for re-election soon? Is the governor not up for re-election? Unfortunately, that's become a major issue here. And I do think that there are some things that are not necessarily based on science. When they come up with some number of how many tests need to be done, some of that is a little bit arbitrary, not necessarily applicable. Like if you do this many tests per 100,000 people, but this county doesn't even have any cases, it doesn't make sense to say you should be doing that there. So there is a lot of arbitrariness. Like I'm looking in Pennsylvania where I live, and the way the governors that have drawn a map of which counties count in which region, that's very, very arbitrary. They had to draw lines somewhere, and some of that is not scientifically based, and it is driven by politics. And you're seeing, for example, in Pennsylvania, over 25,000 exemptions were given for being an essential or non-essential business. So that's a lot of politics. And today in Pennsylvania, we're starting to open up. And one of the things that opened up were private fishing tours. And I wonder how private fishing tours somehow got opened up. So there's definitely influence peddling going on here. And we know that happens at any time that there's a regulation, that there's going to be a cottage industry of trying to get around that regulation. So I do think there's not probably enough science and public health, and there is too much politics here. And the politics has now poisoned the science, because now scientists get put on one side or the other based on whatever position they have, rather than actually being someone that's actually analyzing, giving their best answer.
Yeah. So if you look at a state like California, and which was early and had a lot of cases early, and as you said, the first death was in Santa Clara County, where I used to live a long time ago, and but everything is shut down. And recently, there were some people at the beach, and the governor shut down the beaches as well, and and it seems like it's going to go forever. I mean, he's given no indication, at least certainly through May and maybe into June. What do and then you say, okay, New York is understandable because it was really a disaster. There's no disaster in California. I mean, there might be some stress points, but is a lockdown of the entire state, given the differences in counties and in rural California versus, does that even make any sense?
I think at this point now, things should be based on a county level, looking at what's going on with the cases in a certain area, what their hospital capacity is. And you shouldn't be doing blanket stuff. I think the blanket stuff was just a blunt tool the governors had because they did not know what to do. They were scared to death of what they saw in New York, and they were really nervous about that happening in their state. So I don't blame them for doing that, at least in an emergency for a short period of time. But now I think what you're seeing is a more nuanced approach where you're looking at a county level decisions. And I think that makes much more sense, or regional within a state, not blanket anymore, because states are very different. And there's rural areas and urban areas and places with lots of hospital capacity, places with no hospital capacity. You have to really look at it at a really micro level to get a good idea.
Yeah, unfortunately, I think so many in politics, they have one tool and that's the only tool they know how to use. Somebody's asking how you would compare the coronavirus to the 1968 Hong Kong flu.
So the 1968 Hong Kong flu was one that killed a lot of people. But if you look at the U.S. toll of how many it killed, I do think that this is going to be higher than the 1968 flu. That was a cumbersome flu that did kill tens of thousands of Americans. I do think that this is probably going to be worse than the 1968 flu. This is not going to be 1918, but it's going to be worse than 1968, 1957, and 2009, which were our other flu pandemics.
Good. So anything you'd like to say that I haven't asked about?
No, I think we covered a lot of it. I think this is going to be something that we're going to be watching for a while. And it's important to remember that there's not black or white answers to a lot of this stuff. It's a lot of gray and people trying to interpret things. And there is a lot of controversy in the field about very simple things that we still don't know the answers to. We're learning this on the fly, and we've not, dealt with a pandemic of this scale since 1918. And I think that there's a lot of differing voices within the field. So I think that it's important to remember that not every person in my field that has a position has a political agenda. Everybody's trying to do their best to try and tell people what to do and try to prevent the catastrophe this is. And there is a balance, and people have a different threshold for what kind of balance to strike between the economic shutdowns on the one hand and letting this virus go. And there's lots of false alternatives being created. So I think that that's an important thing, is that everybody's, I think that there's just a lot of differing voices here and a lot of controversies that haven't been quite settled yet. And
it's hard for people to maintain their rationality in this environment. One last question, because I think somebody's asked and he's put a lot of money on it, and I think it's a good question. It really goes to, personally, what should we as individuals do to protect ourselves? Is an attitude that says, I'm going to get this, right? As you said, herd immunity, it's 2 years, 60% of the population might get it. Is it rational to take the approach of, I'm going to get it, we'll just live with it, like there used to be chickenpox parties? Probably not in your generation, but in my generation, we had chickenpox parties. I got every childhood disease out there. I had measles, chickenpox, all of those. And then John asks, it's one thing for us relatively young, although I'm approaching those ages where it becomes deadly. What would you recommend if somebody has an elderly parent? Would you visit them? So just some personal advice in terms of how to manage your own behavior during this.
So I don't like to be overly prescriptive, but a couple of things. I do think that in my mind, I know that I'm going to get this. I might have already had it. I've taken care of enough patients. And today my friends are texting me to go get the antibody test, because some of them are going to go get tested. So I probably do have this. I knew that I was going to get it. It wasn't anything. And I do think most people are going to get it. But it's a different story about potentially exposing yourself to getting that. And the chance that you might be one of those people that has a rare complication. And that's too much of a chance that I wouldn't necessarily expose myself to this on purpose. The fact that I'm taking care of patients is what I chose to do with my life. So that's a different story, rather than be one of those people who exposes themselves and has a horrible complication, or ends up being, one of the small percentage that ends up, a very small percentage that gets sick or has one of those stroke-like symptoms. I don't want to put myself at that type of risk. When it comes to elderly, obviously, I think that if you're somebody at high risk, you should try and avoid this at all costs. We know that high-risk individuals can get themselves into trouble really quickly with that. And I think that's the case. If you are somebody that thinks, I'm going to get this, you have to realize that you're going to probably have contact with your parents or somebody that you might be an unwitting transmitter of this virus to somebody that would be at high risk. And you have to take that decision and know that you're putting other people at risk. And I think it's going to be different for every person. And, I haven't stopped seeing my parents during this. They're both doctors too, so they tend to be less, we tend to be much more risk tolerant of these things. But I do think that you have to kind of make that decision for yourself and what your risk tolerance is, and what the person who's visiting you, who you're visiting, their risk tolerance is, and make sure you actually, if they're consenting to be visited by somebody that might have this virus. So it's very hard to come up with these types of answers for people. I do think it really depends on each person's hierarchy of values and what risk that they want to take. And you have to be responsible and use common sense.
Great. Well, I want to be respectful of your time. I've taken up 45 minutes, which is a lot for you these days. I really appreciate this, Amesh. Thank you. And, keep up the great work.
Well, thank you for having me.
Yeah. And stay safe and stay healthy. Bye, everybody. I'll be back, I think tomorrow. I don't know. We'll see. Bye, guys. Bye, Amesh.